I'm Dr. Reddy, and I'm going to be talking about myalgic encephalomyelitis, also known as ME/CFS. Main objective and goal of this presentation is to provide a comprehensive and up-to-date scientific overview of what ME/CFS is, and I really hope that this talk will shift the perception of ME towards a scientifically grounded biomedical understanding and to call just for, improved recognition and clinical care for those that are affected with this condition. Myalgic encephalomyelitis is a multi-system biological, organic, chronic, debilitating illness that can affect anyone, any age group, any socioeconomic status. In my personal opinion, as a patient that has ME, and I take care of patients who have ME and know a lot of people who struggle to survive with this condition, I think we all would agree that the name, especially calling it chronic fatigue syndrome, doesn't do justice and doesn't accurately represent the severity and the biological reality of this disease because it's not just fatigue. It is involving, neurological, immunological, cardiovascular, and metabolic dysfunctions. And myalgic encephalomyelitis is also imperfect because not all patients experience muscle pain, which is what myalgic means, and encephalomyelitis, which is brain and spinal cord inflammation, is not often demonstrable in patients fully, and it doesn't convey the biological complexity or the hallmark symptom of post-exertional malaise, also known as PEM, which I'll talk about a little bit later. Now, it's been through a lot in history, but the World Health Organization's International Classification of Diseases, which is our ICD-10 codes, actually recognized ME as a nervous system condition in 1969. But it wasn't until October of 2022 that both ME and CFS were coded identically and classified as like nervous system disorders together. And prior to that, we had like unspecified chronic fatigue syndrome, and like this caused a lot of, separation when it came to tracking and recognition. So I'm really glad that they are now grouped together with also post-viral syndromes. Emmy has had a very painful history, and this condition has been neglected for so long. And so I wanted to go back and show people what the reality was and what we have gone through and why we're still having such a hard time for recognition. And it's just because it's decades of clinical ignorance and systematic effort to trivialize the scientific realities that has led to so many people getting harmed. And there are several reasons for that. And honestly, they're unforgivable. So ME was first defined in 1984, but the existence of ME has been described as far back anywhere from the 17th to 19th century. In 1681, Dr. Thomas Snednum, a English physician, actually described what we now think was ME, and he described it as a muscular rheumatism. Throughout history, there have been epidemics and sporadic forms of ME popping up, especially since the 1930s, but people have always downplayed it. There was actually a larger outbreak of poliomyelitis in the United States and, several clusters of ME around that time. I think it was like 1934, and this was in Los Angeles, California. And people were describing it as like an atypical polio, but looking back in history, that was like clearly ME/CFS. Big one was the Royal Free Hospital outbreak in 1955 in London, where there were hundreds of long haulers, like a bunch of like healthcare workers, and about 255 patients got sick in this event. And most of them were admitted. So it was after this outbreak that the medical journal Lancet published about ME, but it was still not taken seriously because two psychiatrists who, by the way, didn't meet a single one of these patients in person or examine them, and just negligently labeled this outbreak as mass hysteria on the sole basis that women, predominantly women, were affected. which then brings us to, throughout history and even till today, this virus of medical misogyny and gender inequality. And, women are just not believed to be reliable witnesses of their own body. Like, our lived experience was never taken seriously, and they were often dismissed and psychologized. And again, that goes back to show that there's just this really deep-rooted, gender bias in medicine. Also, this very deliberate, systemic dilution and effort to trivialize what ME is and the diagnostic criteria by focusing on a very unmeasurable symptom of fatigue while ignoring, the multi-system nature of this illness. Unfortunately, I've seen some of the same patterns of dismissal and history kind of being repeated with this COVID-19 pandemic, which brought on a pandemic of long haulers or those with long COVID and other post-viral syndromes. And it's really unfortunate that they too, millions, are being hijacked and mislabeled as a psychiatric illness when in reality, that's not what we have. So the global statistics and the economic and healthcare impact of this is something that we really do need to address, because I fear that there are millions of people with this. ME/CFS is not rare, and the true prevalence is not known, as you can see from history, and the fact that very few doctors have expertise to diagnose this. And what also further confounds to the problem is roughly 84 to 91% of people have yet to be diagnosed, which means so many are undiagnosed. And based on the data that we have thus far, at least pre, 2020, the worldwide prevalence of it was around 67 million people, and that was roughly about 1.3% of the United States population, which was anywhere from 3.3 to 4.3 million Americans. I mean, that's a lot of people. And then you now have this growing and increasing prevalence due to the COVID-19 pandemic. So there's probably millions more worldwide. You're going to see how profound of an impact ME can be, and it takes people out of the workforce. And with that, there's high medical costs, and that also contributes to a very huge economic burden. I've seen 17 to 24 billion dollars annually of a deficit, and that's a lot. And I really wanted to show this figure right here because it shows, hey, look, there's a lot of people dealing with this, right? And actually more than HIV. But if you look at the amount of money that we are, increasing every year for AIDS research and HIV research, and ME is just getting smaller and smaller. And the reason that is because people are again saying, oh, this is all in your head, when it really isn't. And that's why I really want to stress that this needs to be taken seriously, because it's just going to be a growing problem. And you can see that ME is severely underfunded in relation to the disease burden. And the reality is, the cost of inaction is going to be more expensive for us than actually investing in the research. One thing that I really wanted to stress, that we really do need funding so that in the long run, this won't hurt us as much economically. Roughly about 70% of cases are caused by some sort of infection, so post-infectious. And this can happen after viruses like Epstein-Barr virus, cytomegalovirus, other herpes viruses, enterovirus, parvovirus B19, and then the coronaviruses like SARS-CoV-1, MERS, and SARS-CoV-2. Now, people can get this even after asymptomatic infection, which I talked about in the long COVID lecture, but you can also get this after non-viral pathogens, so bacterial pathogens like Borrelia or Lyme, Campylobacter, Giardia, Q fever, and so forth. And infections are not always our cause. It can also happen after vaccines. It can happen after surgery, after an accident, childbirth. So there's other things that can set it off. And I really love this diagram, and I'm going to talk a little bit about the different cellular, mechanisms and pathophysiology, but just to kind of hit it briefly, we've got endothelial dysfunction, we have neuroinflammation, we have viral reactivation as the cause, we have gut dysbiosis, we also have cellular metabolism issues, immune system dysregulation, autoimmunity, and then mitochondrial dysfunction as well. It is a multifactorial systems failure, and you can see these are some of the big systems that are affected. With the neural systems, it involves brain inflammation. You also have dysregulation of the hypothalamic pituitary axis. You also have, alongside that, peripheral nervous system damage. So some patients might have small fiber neuropathy, and then that kind of dips into the dysautonomia, the autonomic dysfunction, which then, causes orthostatic intolerance, which then affects the cardiovascular system and the endothelium, which then compromises how blood is perfused throughout the tissues. Immune system, so immunological function, is characterized by a dysregulated immune response, and we have some sort of chronic inflammatory activation as well as mast cell disturbances like MCAS. And lastly, the big category is the cellular level metabolism impairment with the mitochondrial dysfunction, and that affects our energy production. Post-exertional malaise, or PEM, is also known as post-exertional neuroimmune exhaustion, or PENE, and the other name is post-exertional symptom exacerbation, PESE. So this is a biologically explainable phenomenon, and it is the cardinal feature that is pathologically where we have the inability to produce sufficient energy to function. And that leads to a whole host of issues. Essentially, what's happening is patients have a worsening of their general symptoms or the development of new symptoms anywhere from 12 to 48 hours on average. But I have also seen a delay up to 72 to 96 hours after they do some exertion above that patient's specific energy envelope threshold. So we all are different. We all have like a maximum that we can and cannot do. That could be some sort of physical task, or doing some sort of cognitive or mental task, orthostatic, standing up for too long. It could be environmental stressors like bright lights or really loud sounds, or just too much stimulation or inputs into the brain could be enough to trigger it. It could be chemical exposures. So all of these different things are PEM inducers or triggers. What's really devastating is that this post-exertional malaise can lead to very profound crashes or collapses. I saw a patient for 4 hours and I had a crash in the afternoon. That is what I'm talking about, where I have depleted my energy envelope. And for some people, it can last a day, 2 days, it can last weeks, it can last months, or it can last much longer. And that's what's so debilitating and unpredictable. Don't know how long lasting or devastating it could be for a patient. And it is. There's a profound stamina loss, reduced functional capacity, reduced metabolic efficiency, the autonomic dysfunction, your immune system dysfunction. That's why a lot of us feel like we have the flu. Concerning is this prolonged recovery, right? That is out of proportion to something that was once tolerated. This is an impaired physiologic state, and that is why a lot of us get worse when we exercise, and so many providers push us, push us, push us, and then we get worse. We deteriorate. Exercise is not medicine for this population. There's so much research out there that is discovering the biological mechanism. So I'm really hopeful that we're going to have a biomarker soon that we can use to identify these patients. The DePaul symptom questionnaire is a really great one after you have diagnosed someone with ME/CFS. It distinguishes essentially post-exertional malaise, PEM, from generalized fatigue that's often seen in other conditions like depression or deconditioning. Has been an association of preload failure, which again goes back to kind of this autonomic dysfunction with the vasoconstrictor response not working. There's also this metabolic switch from aerobic to anaerobic glycolysis, which is essentially a breaking of that cellular function that produces our ATP. Microclots theory, which then is blocking microcirculation. It's affecting at a cellular level if we're getting oxygen to the tissues. And then there's this 2-day cardiopulmonary exercise testing that is showing objective evidence of clinical deterioration after exercise. And then there's also alterations in the immune system. In our cells, we have this structure called the mitochondria, which is known as the powerhouse of the cell because it plays a crucial role in energy production. Right here, we have our citric acid cycle, or also known as our Krebs cycle, and that plays a huge role in kind of this process of generating our ATP. And that does so using an oxygen pathway, an aerobic pathway. Those of us who have ME/CFS, unfortunately, this pathway is broken. Mitochondrial dysfunction is another huge reason why we don't have the energy capacity to regenerate quicker or efficient like a normal healthy person. Autoimmunity is another thing driving our condition. Research has found a pretty substantial amount of evidence to show that we have this autoimmunity to these G protein couple receptors. These receptors are a very large family of proteins that are found throughout our body, and they do various functions. If you have autoimmunity to these receptors, you're going to either have activation or inhibition of those receptors and their functionality. For example, they can affect, the autonomic nervous system, they can affect our immune responses, and also our vascular tone. A lot of people with ME/CFS are showing these autoantibodies, and specifically the beta-2 adrenergic receptor, and there's also muscarinic acetylcholine receptor autoantibodies, and these are actually correlating with symptom severity in patients with the fatigue and the muscle pains and their PEM. Other things, like we kind of mentioned before, the endothelial dysfunction. Unlike, classical cardiovascular disease where we can see an elevated CRP, we typically don't see that. We have to do more specific microRNA profiles, which is what like a lot of researchers are focusing on to try to get a biomarker in this area, because it can show us if there is underlying vascular inflammation, then affecting the coagulation system and causing these small microclots that are then damaging, the lining of our blood vessels called the endothelium. Gut-brain axis dysbiosis, this is a huge driver, and it's causing, systemic as well as the brain inflammation, because there's this elevation of pro-inflammatory cytokines, and it's causing this kind of neuroimmunologic storm field to set off viral reactivations in the gut and elsewhere. They have also found in research through PET scans that are showing this neuroinflammation, and it's showing, you can see here, it's affecting key parts of the brain that are very, very important. Could be why a lot of us are having that cognitive dysfunction. Some of the common symptoms of ME/CFS, autonomic dysfunction in a lot of us are worse in the upright position. So we have that orthostatic intolerance, and then we have the post-exertional malaise. We know those immunologic impairments, sleep disturbances, hypersensitivities, all the things that we kind of already touched on. Diagnostic criteria have these 3 criteria, which includes at least 6 months of profound fatigue, impairment, reduction in, your daily activities, and post-exertional malaise, the unrefreshed sleep, right? All of us might be sleeping 10, 12, some sleep even longer, 16 hours, and they still wake up like they haven't slept at all. And so they might go get a sleep study done, and the sleep study is completely normal, but they're still having this profound non-restorative sleep. Patients have to meet at least one of these, so either cognitive impairment and or orthostatic intolerance, and most of the time they have both because they're not getting good blood flow to the brain. This is a really good diagram to show people like what is involved in the diagnostic criteria, and then additional symptoms, which we kind of already mentioned, which are mainly neuroimmune and neuroendocrine, with the flu type symptoms, the GI symptoms, and so forth. I do want to reiterate that most patients have a very unremarkable physical exam, and you do not need to have an abnormal physical exam finding for diagnosis. I will say that if you carefully observe these subtleties, you might be able to pick up on ME/CFS because of that autonomic disruption, and they're kind of bouncing between sympathetic and parasympathetic. There's some pupillary oscillation where it might be like dilating, constricting when exposed to light. Suborbital shadow, essentially like kind of like, like a subtle dark circle. You look in the back of their throats at the pharynx pillar, like red demarcation. Again, get these flu-like symptoms, so you will have very palpable and tender cervical lymphadenopathy. I actually have some right now. So axillary lymph nodes. I even ask about the groin because sometimes they're like, oh, my groin is hurting and I don't know why it's sore. So that could be a sign. Must have some muscle tenderness, some joint pain, very unusually cold hands and feet because of the dysautonomia. Might have like a low-grade fever, and that notice throughout the appointment that they might be a little bit able to engage at the beginning, but as the appointment goes on, they get a little bit more fatigued. They're not as responsive, and they might need to lay down. I have trouble answering questions because the cognitive issues starts flaring up, and a lot of us can't tolerate coming to the doctor because of all the bright lights and sounds, and so you'll see them in sunglasses or earplugs to kind of reduce that. I don't have right now a biomarker, but these are generally the labs that I do to make sure that I'm not missing anything. You got to make sure they're not anemic, thyroid dysfunction, adrenal insufficiency, full autoimmune workup, because sometimes some of these autoimmune conditions overlap with ME/CFS, vitamin deficiencies, B12 deficiency, magnesium, vitamin D, iron deficiency. Ferritin is often found to be very low in a lot of these patients, especially long haulers that have ME. And I think that's because of the chronic inflammation and the viral reactivation and utilizing some iron stores for their evilness. There's over 1,200 mediators for mast cell activation syndrome, and we can only test for like 10. So the chances of us actually picking up on one is fairly slim. Nonetheless, these are options to check for viral reactivation. Checking for EBV is very common. Over 90% of the population has been exposed to EBV. Often one of the driving forces for ME/CFS. You got to check your herpes viruses as well. And always, I like to make sure, I'm not missing any sort of immunoglobulin deficiency. I really want to tell people, just because these labs might be normal or slightly off and not point to maybe what's going on, it's because we do not have the right blood test right now to check for this. I believe the patient over any blood test, 100%. I wish I could do a whole lecture on treatments for ME, but this is a really good diagram that kind of shows the main treatments, a lot of trial and error and trying to figure out what do we need to tackle first. Big things that I like to tackle is the dysautonomia, and I also like to go after the mast cell activation syndrome. Other big thing is what I hate so much and have such a hard time to do, because it is legit a Olympic sport for me, is pacing. Learning to slow down and conserve your energy, probably the biggest challenge. We got to pace our mental and physical activities to fit our narrow, energy expenditure and avoid exacerbation. National Institute of Healthcare Excellence, NICE, 2021 actually changed ME/CFS clinical guidelines, and they emphasize that pacing is so important to avoid PEM. Have said, nope, you can't do graded exercise therapy. Stated that cognitive behavioral therapy is not the treatment for this disease. I really appreciate this acknowledgement that this is a physical illness and it can't be cured with, some sort of exercise or psychological behavioral therapy. ME/CFS affects each person, varies, and it also waxes and wanes depending on the day, what you're doing. It's kind of categorized into mild, moderate, severe, but I just want to state, there's nothing mild about even the mild zone, because it's still very difficult, but there are people who are in a more severe state, about 25%, where they're completely homebound and bedbound and they're not able to function. They need full-time care. 25% of them might be mild and they might be able to participate in social activities. 70 to 75% of ME patients cannot work or require a decreased work schedule. And that just shows how disabling this can be to the functionality and how it can affect people. This image actually does a really good job kind of describing what it feels like. For me, I describe it as this deep bone exhaustion, unchanged by sleep. Like I'm charging my iPhone and it won't go past 10% or it won't go past 20%, and I have to keep plugging it in to charge. Using 20% of their core battery to take a shower, to eat, and to get some fresh air. And that's enough to wipe them out. People who have it pretty severe, they describe it as this never-ending torture of living death, and that's accurate. Can you imagine being buried alive and you want to do, but you can't? Being confined to your bed, not being able to do basic tasks to take care of yourself, like toileting. Terrifying for someone to lose that level of capacity. That's why I want people to listen when we say this is real. It's just hurting so many people. So quality of life, when you compare this to other disease processes, you can see ME/CFS has the lowest quality of life score. I don't like to compare to other illnesses, to be honest, because to each their own, but just for people to gain perspective, this is worse than HIV/AIDS, congestive heart failure, heart disease, diabetes, cancers, multiple sclerosis, COPD, and so many other maladies. It takes so much of our life away. You can imagine the emotional toll that it takes on us. There's just this profound loss of life, right? Your health, your social connections, your careers, finances. It's devastating. And the uncertainty. Those of us with ME/CFS often have a mood change, but that is not the cause of our illness. That is a side effect, just like it is a side effect with anyone who gets any chronic illness, going to develop anxiety and or depression as a secondary consequence, but not the causation of ME. ME/CFS is not deconditioning. And it goes back to our body not being able to generate that ATP, and then that affects the entire body system. I talked about earlier with the 2-day cardiopulmonary exercise test, it really showed that those with ME deteriorate very quickly. And that is the exact opposite of what happens when someone is deconditioned. They get better, right? If they train themselves and do. But for us, we get worse, which is why it's not deconditioning. The Institute of Medicine in 2015 did state that ME/CFS is not a functional neurological condition, conversion disorder, psychosomatic. And in history, so many patients were misdiagnosed this way. And even now, I see patients that are diagnosed with functional neurological disorder, and I examine them and I'm like, no, this is ME/CFS. The CDC also has acknowledged that ME/CFS is a biological illness. It is not a psychological disorder. We're not trying to get anything out of this. We're sick. We want to live our lives. Why would we fake this? Why would we want some secondary gain? We want to live, we want to do, but we're physically not able to. Really important, I think, that ME/CFS is differentiated from psychiatric conditions because, like I said, we can have both. Unfortunately, it's all being bucketed into the psychiatric category without actually looking at, oh, there's something else going on here. And I think it's really important to recognize which symptoms are not caused by mental illness and which ones are. So with ME/CFS, right, there's some sort of immunologic trigger, whether that's an infectious or a vaccine or something else. Whereas in major depression, it rarely, hardly, less often followed by some sort of infectious cause. We have the hallmark PEM, which is necessary for diagnosis, and we get worse with physical exercise, whereas in major depressive disorder, MDD, fatigue and mood can improve for some with regular exercise. You have the headaches, the flu-like symptoms with ME, but with major depression, it's not that highly associated with muscle or joint pain. There's also, more orthostatic symptoms, orthostatic intolerance, tachycardia, and currently there's no universal association between MDD and all autonomic nervous system symptoms. I will say that those with very severe depressive symptoms do have a slower gastric emptying, indicating some sort of autonomic dysfunction here. You have these neuroimmune symptoms, right, with the tender lymph nodes, the sore throat. There is a potential for an inflammatory pathway activation, but you typically don't see these symptoms that you see in ME/CFS in MDD. There's also no temperature problems in MDD, whereas you do have that in ME/CFS. Patients with ME/CFS usually have a decreased positive affect, right? Enthusiasm, happiness, just because of their situation. Whereas in MDD, people are very hopeless, very apathetic, might have suicidal ideation, anhedonia, which is loss of pleasure in their previous activities. So ME/CFS patients often present to multiple specialists, including psychiatrists. Patients and clinicians should monitor and see how they do, because a lot of my patients are put on antidepressants or anti-anxiety medications and see if they improve, because if they do improve, then yeah, like maybe we're helping their psychiatric symptoms, but if they're not, then maybe we got to think about ME/CFS, right? And that can help us validate a diagnostic hypothesis, because there is literature out there showing that antidepressants do not improve our core symptoms of ME/CFS, right? Because we have a biological pathological cause. And that's really important for psychiatrists to recognize as well, when to redirect investigation when you notice that your patient is not improving, even though you're helping them with psychotropic treatment. Other thing I want to mention is patients with ME/CFS, we are actually very sensitive to medications. And so if you notice that you're not able to tolerate meds that you've been on for 10, 20 years, or like your ADD medicine is actually making you worse, even though it's been stable, then that might be an indication that something else is going on here. This is why we need very robust biomedical, neuroimmunologic research to take precedence over, psychological therapies, because this is predominantly a physical condition. We really need to continue advocating, amongst our doctors, amongst researchers, our insurance companies, policymakers, because that is the only way we can move this needle and move the current state of science. This is a legitimate health condition, and it's an alarming condition that is affecting millions of people. So we really do need to take action. It's not a psychological or a gendered phenomenon. ME/CFS is not a diagnosis of exclusion. It is a diagnosis of systems failure. But it should be instinctual that, oh my gosh, this patient has ME/CFS, instead of hopping around all these doctors and dancing around, oh, maybe something else. It should be instinctual. Look at all these systems that is failing. Maybe this is ME/CFS. So these flowers are forget-me-nots. Symbolizes remembrance and enduring love and a deep commitment to never forget all of the people that tragically lost their lives to ME/CFS. All of these people that died by, assisted suicide, or just by, organ failure. Their lives were tragically lost because of systemic failures over probably centuries. Institutional neglect, medical gaslighting, the use of harmful therapies like graded exercise therapy. Tragedies underscore the need for more advocacy, for more funding into ME/CFS, better education or continued medical education for healthcare providers, the development of better treatments to alleviate our post-exertional malaise and to prevent further loss. I honor those who are no longer with us by advocating and by pushing the truth so that we can create the change that this community deserves. I really encourage everyone to have an open dialogue, to persistently advocate so that we can change these entrenched belief systems that have been ingrained in our society for far too long. We still have a lot of work to do, but I have already seen so much amazing work by so many people that change can happen and is happening, even if it is happening slow. I really want to thank the efforts of patients, compassionate clinicians, and other advocates, caregivers, for all the work that you're doing to help pave for a better way. You are absolutely part of this hope for a better future for everyone that is affected by this condition. This is a hard subject to talk about, but I hope that you now know a little bit about ME/CFS and how important it is that we continue our fight. Thank you.